So you know the AML, and actually all the acute leukemias, the genetic heterogeneity is very complex. Okay, and it is not just the driver mutation which makes it complex, but it is the subclonal mutations which can play havoc in the development of resistance, which is important. And then also the acute myeloid leukemia is a disease of the older people. As you get older, the incidence increases, and the median age is now approaching that of 68, 69, at least in the Western world. It's probably a little younger in the Far East than other parts of the world. And so one of the complexities which we have from the genomic perspective is that as you get older, there's a number of mutations which may or may not be pathological begin to arise. Okay, say for example, in the last 7 or 8 years, we've been talking a lot about a phenomena which is known as clonal hematopoiesis of indeterminate potential, or CHIP. Okay, you could also call it ARCH. Acquired somatic mutations related to age. And what happens is that this is the collation of different candidate mutations, and one or two of them have actually been found to be drivers in myeloid malignancies as well. But a lot of the time, they may not be pathogenic. Okay? So the fact that you identify this mutation in a particular individual doesn't necessarily mean that it will be the driver in that case. Okay? So, and this is the one part of the complexity. The other part is that the AML in particular, the majority of the patients have at least 2 or 3 driver mutations. Okay? And the order in which you acquire these mutations may actually impact the phenotype of the subtype of AML and the prognosis and the predictive aspects in terms of responding to certain therapies as well. And then the relationship between the different mutations as well. Okay? So I think the long and the short is that everything is a double-edged sword. Okay? So you have a lot of good things in one side and you can match therapy, but if you're not careful, it can also be detrimental. You see, the functionality of these different mutations in the different tissues is an area which is so poorly understood at the moment and is so critically important, okay? Because different mutations in different tissues have a different property. But collectively, it's all of course very exciting because it has led to a number of new therapies to be available. In AML, for example, up until 5 years, we had very few drugs which had been approved in the previous decade. And other than acute promyelocytic leukemia, which is another poster child for personalized therapy, there was no real targeted therapy. But now we have 5 drugs which were approved just in the short period of about 3 or 4 years. And there's another 1 or 2 in the pipeline. And then in the area of acute lymphoblastic leukemia, there's a number of targetable mutations which have been described, in particular the so-called BCR-ABL-like mutation, where the genomics are very similar to those we have in patients with CML, and many of them are amenable to the tyrosine kinase inhibitors with very, very good results. But there's still a lot of work to be done in ALL as well. Yeah.